Thank you so much for joining us for our final fall series CE event in our monthly Child and Adolescent Professional Development series. I am Donna Bartlett. I am a member of the outreach team here at SunCloud Health. SunCloud Health provides integrated, nuanced treatment with residential, PHP, IOP, and virtual services for adults and PHP and IOP for adolescents ages 12 to 18. Also, our new res opened in Madison, so also residential for adolescent females from 13 to 18 still in high school. And we are treating the whole person in Naperville, Northbrook, Lincoln Park, and like I said, Matson. If you are interested in learning more about our services, my contact and Lori Kehoe's contact information will be included in the last slide for your reference. To make a referral, you can contact either one of us directly or call our intake number that's listed. Lori and I will be following up with you all as well after the webinar. Please note to receive your CE credit today, you will need to remain on Zoom for the entirety of the presentation. Also, you will receive an email including the quiz and the survey. Please complete these to receive your CE certificate by email. You should expect to receive it in about 10 days. Okay, I'm so excited to introduce our presenter for today, Shawntrell Moore, who is an LCPC CADC. He is our residential clinical site director at SunCloud Health, where he provides clinical leadership and oversees trauma responsive, evidence-based care for adolescents and family. He is, like I said, a licensed clinical professional counselor and certified alcohol and drug counselor in the state of Illinois, with over 17 years of experience in the behavioral health field. Shawntrell earned his master's degree in human services from the University of Illinois in 2011 and his bachelor's degree in criminal justice from also University of Illinois in 2007. His clinical approach integrates cognitive behavior therapy, dialectical behavior therapy, solution-focused therapy, and Gestalt principles, all delivered through a trauma-informed motivational interviewing framework. In his role at SunCloud Health, Shawntrell focuses on creating a safe, structured, and empowering environment that supports healing, resilience, and long-term recovery. Thank you, Shawntrell, for being with us today, and I'm going to let you take it away. So exciting.
Thank you, Donna. Hi, so yes, I'm Shawntrell. I'll be facilitating the presentation today on trauma-informed care for youth in the school setting. If you do have any questions, go ahead and put those in the chat. I do believe Donna will kind of help field those for me. And then we'll also have some time at the end to also answer some questions as well. So I'm
Yeah, if
excited
you
to do
want to
this.
change the slides, Chantrell, to your
Yes,
slides. And like,
yes.
sorry, like while you're doing that, I just want to say, yeah, like definitely like put them in the chat. And I know Chantrell will be happy. Like I might interject throughout the presentation if there's a bunch of questions and Chantrell will take them. But otherwise, we will definitely answer them at the end. Sorry. Thanks, Chantrell.
Of course. Okay. All right. So I want to kind of start off by just sharing a little bit about me. And, a lot of my passion for trauma actually does stem from some of my background. And I wanted to share, one of my experiences and, that helps kind of guide me, um, as I continue, learning about trauma, building my clinical skills with trauma. But, me having my own foundation definitely helps, I believe. And so, the first thing I want to start off with is I want to start off with a personal experience of mine. So, in childhood, I excelled in quite a few different things. One of the first things I remember excelling in was spelling bees. I just had a thing for words. I love words. Once I see a word, it's a lot of times kind of stays with me. So I was involved in spelling bees growing up. I was involved in sports, some math achievement tests, and math achievement. Just experiences. I guess I had science projects. Some of my favorite times reflecting back was actually, sometimes playing football, even before school. I don't know if, people still kind of do it in the way that we used to do it. We were very rough as we would play tackle football, right before school. And then some of my favorite memories too, reflecting back, were times when my brothers and I was in a household of uh, eight kids, and my brothers and I, we would always run and race the school bus coming, and it was always exciting whenever we would be somewhat late, a minute or so late, and we would be like running after the bus. I just remember like some of those positive memories I had. So I grew up in foster care as well, from age 1 until I aged out. I stayed in the same home, which is very rare looking at the stats, to stay in one home and in foster care from 1 until you age out. But yeah, that was my experience. And then, like I said, I kind of grew up with 8 other kids in the home as well too. One of the first things that I learned about growing up in the foster home is I learned about secrets. I learned about actually keeping secrets. One of the things that was told to me kind of early on was, you know, by telling other people what's going on in this home, you could be taken out of here, actually. So be very watchful with what you say. Be very watchful with what you share. In fact, I remember a couple times my foster mom would tell me, "Hey, the caseworker's coming today. Make sure you're on your game. Make sure you're not going into deep detail about anything." So I kind of had that type of dynamic, with authority growing up. That was learned as like a survival tactic to keep secrets, basically. And then something that I learned from there is, and just reflecting on it, I kind of learned that being sometimes honest, there will be consequences. And then, therefore, sometimes in the school setting, as I will be dishonest, there will be consequences. So, just wanted to kind of point that duality out right there. And then the second thing here, the questions about vacations and time spent with family over the summer. A lot of times I kind of shied away from that conversation. A lot of times when I reflected on my summer, I was most of the time kind of worried about where I was going to be living. Am I going to still be living here? I was always, and so that was kind of, always kind of a moment of deflation whenever we would come back to school and we'd have those questions about what all did you do over the summer? Was it exciting? And, that type of thing. So just knowing just even a simple question on how that can be very triggering for kids, I think is important to point out. And then there was one other dynamic that was actually pretty interesting. You know, there were a few of us who were in the home who were the foster kids, and then there were the real kids, and that's actually how we would refer to ourselves. We would talk about each other like in the way, oh well, the real kids. And as I got older, I realized like, whoa, that's heavy. But that's how we talked actually in that home. And then some of what was struggling, I think for me personally, is sometimes I would actually engage with my foster mom, and I would sometimes I remember one conversation I had with her. I remember asking, why would you get rid of us after you've been raising us all these years? Why would you threaten that to us? And I remember her coming back to me a little while later explaining, oh, actually, that conversation we had when you were like 8 or 9, you coming to me, that was actually one of the reasons that helped change my mind. She told me that later in life, which was, yeah, interesting. And then some of what came from that questioning of my value, question of my worth, there was a lot of attention seeking. There was a lot of negative behaviors as well too. And then even that little comment that I mentioned down there, why was I never adopted? So something, if you don't know, with foster care is, you can be in foster care and then you can be adopted. And then in that home, there actually was one other child who was adopted, but I wasn't adopted, and that type of dynamic was there. So of course there were a lot of issues with that, favoritism, this and that. And so for me, what I started kind of learning like over the years is, I wasn't really getting, praise and acknowledged for a lot of good things. I was getting so much praise, attention, and acknowledgement from actually bad things. So that kind of was a little part of my journey, throughout some of my childhood and in my teenage years. And then I mentioned there the bullying experience of, learning how to resolve things, through that way, which then impacted me as I started kind of engaging in some of that behavior for a little while. And so for a lot of my experience, and then I'll move on. A lot of my experience really was lots of detentions, lots of write-ups, suspensions. One time I remember even a school official sitting me down and say, "Hey, if you do one more thing, you will be expelled." And that was actually a breaking point for me, actually. There was a shift right at that moment. But yeah, so that was some of my experience that I wanted to just kick this presentation off with.
Chantal, thank you so much for sharing. If you
Mhm.
could just hit the slideshow button because
Oh,
it'll take
yeah,
up for the
yeah.
whole screen. Sorry.
Okay. Oh, okay.
Thank you. Sorry.
Yeah, no problem. Okay, so I have a couple of quotes here. Trauma is perhaps the most avoided, ignored, belittled, denied, misunderstood, and untreated cause of human suffering. This is from Peter Levine. Peter created the somatic experiencing trauma modality. And then the next one here, children are coming to school with trauma, everyday trauma that they live under. We need to help treat that before they can even go sit in the class and learn about math. This is Denise Junot, who was a school official. And then for some students, school is the only place where they get a hot meal and a warm hug. Teachers are sometimes the only ones who tell our children they can go from an Indian reservation to the Ivy League, from the home of a struggling single mom to the White House. Okay. And then this last one, I really like kids with trauma history don't need more punishment. And quite frankly, they don't need more stickers. Dr. Ross Green. Okay, so yeah, really wanted to hit home on those quotes. The thing is with trauma, and I'm gonna kind of go more into this, but the thing with trauma is, a lot of us have experienced trauma. A lot of us professionals, teachers, parents, have experienced trauma, and I really do like the idea that traumatized people are helping traumatized students, sometimes in a system that can be re-traumatizing, and so when we look at like organizations, different organization systems, we know that trauma can play out in the way that those systems are carried out. And so yeah, I think as we go through this presentation, I think a lot of people can really relate to this, and so we're not alone in this. um, So I think it's important that we break down, what trauma is. The simple definition that I always like to use is truly that trauma is an emotional and physical response that overwhelms one's ability to cope. So that's just, one simple way of really remembering that. But the definition further down, I really like is very thorough. It's very inclusive of different aspects on how trauma plays out. So yes, trauma results from an event, series of events, or a set of circumstances. That is, trauma results from an experience by an individual that's physically or emotionally harmful or threatening that has lasting adverse effects. Trauma results from effects on the individual's functioning and physical, social, emotional, or spiritual well-being. So if you look at that equation there, trauma equals event plus experience plus effects. Um, Here are some trauma responses that are very important to know. So whenever someone is experiencing trauma, they may engage in one of these trauma responses um, at the time, maybe of said event, and then that response may continue to be carried out, depending on, if there's re-traumatization going on or not. So the first one is fight. The next one's flight, freeze. Those are ones we mostly hear about. We know that fighting in response to trauma is really you engaging in, some physical or psychological combat of some kind. In that moment, we know that flight would be a person fleeing. Um, in response to that trauma, and then, freezing up, self-explanatory. A person would be still, not able to move, not able to respond at all. And then fawn, this is when someone is becoming um, extremely cooperative, appeasing, people pleasing, subservient to typically a person who may be in a dynamic where there's more power over that person, or sometimes you see that dynamic in domestic violence situation with abuser and victim. But basically, become passive and you become appeasing, overcorrecting, all in a way to avoid conflict. So these trauma responses are actually normal. And what's important for a lot of students, clients, patients, what's important for them to know is that while those responses are normal, the trauma in and of itself is more of what's abnormal. Okay, so the response normal, the trauma event is what's abnormal, and that's important for people to know because people will actually flip that. People will actually look at their trauma responses as abnormal. In fact, people will judge themselves very harshly with the way that they responded to trauma. If they didn't, um, step up to their abuser. Sometimes if they froze or if they ran away, depending on what the trauma was, people will be immersed into shame a lot of times. And sometimes you see that being a huge barrier in people healing through their trauma. Sometimes it really is the judgment that people place on themselves in response to their trauma. So some of the work that helps with that healing is actually addressing that a lot of times. The next thing I want to touch on is ACEs, adverse childhood experiences. And so ACEs is a tool. It's an assessment that basically questions people about their childhood experiences. I do have a few listed here. Um, these were pulled from the National Survey of Children's Health. These are more so kind of like topics that are covered in usually in the ACEs questionnaire. But as we move on, you'll see that there's actually way more to it. But here's kind of just a kind of starting point on things that are asked about when assessing childhood experiences that are actually trauma. So the first one is parent, guardian divorced or separated. So this is asked about in these assessments. Parent, guardian died. Parent, guardian served time in jail. Saw or heard parents or adults slap, hit, kick, punch one another in the home. Was a victim of violence or witnessed violence in his or her neighborhood. Lived with anyone who was mentally ill, suicidal, or severely depressed. Lived with anyone who had a problem with alcohol or drugs. Was treated or judged unfairly because of his or her race or ethnic group. Okay. So one of the reasons on why ACEs is important in the mental health field is because the more a person experiences these, the more negative outcomes they might be exposed to, that they might be at risk for. So this tool is really, really helpful in a lot of ways. One, because if we're able to capture that a person has experienced these amount or this amount of ACEs, then we can address it early on a lot of times. And, we can look at the risk of what can happen if we don't address it. We can look at the studies, we can look at the outcomes of what can happen or what likely will happen. And these can be, things like diabetes, cancer, suicide risk, different medical conditions. We can all now kind of look at the data and we can see that, okay, this person experiencing five or six different ACEs, is 5 times more likely to develop this, the onset of this. So it's actually pretty interesting, fascinating work to look through and very important for the field. And I'm going to touch on a couple other things with ACEs. Mm. So here's some of those examples I was just kind of mentioning, the impact of ACEs. And so, with some of what I was just mentioning, and that's really there's so much more to what a person can experience, as I know everybody knows. It's not just those questions or those topics that determines, a traumatic event, but that's just kind of a base there. But just looking at those, the impact of 4 ACEs or more, you are 2 times more likely to binge drink and have a poor diet. If you have 4 ACEs or more, you are 3 times more likely to be a current smoker. 4 ACEs or more, you are 4 times more likely to have low levels of mental well-being and life satisfaction. 4 ACEs or more, you are 5 times more likely to have had underage sex. 4 ACEs or more, you are 6 times more likely to have an unplanned teenage pregnancy. 4 ACEs or more, you are 7 times more likely to have been involved in violence. 11 times more likely to have used illicit drugs, 11 times more likely to have been incarcerated. Okay. Um, ACEs has been expanded over time. ACEs was first created around 1995. Since then, there's been a cultural um, orientation that's been added to it, which has been, I think, very, very helpful for many, because the ACEs was kind of more based on kind of the standard, I believe, white male, but now adding kind of a cultural kind of aspect to it, I think it definitely covers. Um, Different traumas for sure. Another question that definitely is now considered for the ACEs questionnaire is how has your race or ethnicity affected your experiences growing up? Did you often feel unsafe in your neighborhood due to violence or police presence? Was your family ever unable to afford, were they ever unable to afford food or housing? Did you experience racism from teachers, police, or healthcare providers? Are there cultural traditions or community connections that helped you feel strong or supported? And that one would be more of a protective factor. And just to also kind of name a few right off top that might also be specific to the school setting. There's now cyberbullying that's going on. There's now I guess this isn't like a now thing, but what isn't also captured in the ACEs is sometimes like what you're hearing about your friends, when it comes to really terrible, terrible things. One being suicide. That's one thing. Just hearing about that can definitely be an ACE, as sometimes when other people have experienced something so terrible, or when another person has experienced a trauma, you learning about that or hearing about that, a lot of times can bring on trauma symptoms to you, and that's what we would call vicarious trauma. So just hearing and learning about traumas definitely can bring the onset of trauma symptoms to you for sure. So here's some bullet points I want to touch on with the traumatic experience, just so that we can kind of go over some things that are maybe somewhat confusing when determining trauma. The individual's experience of the events determines if it is a traumatic event, right? We know that that's very important when assessing trauma. You may have 2 brothers, or you may have a brother or sister, you may have a sibling, and you all may have experienced the same thing, but one person has responded to it in a whole different way than the other sibling. One person may view and heavily perceive their experience as trauma, and they may in fact have trauma symptoms. The other sibling might have had a whole different experience, based on the way that they perceived it, they experienced it, and that type of thing. So we know that the person's uh, view or perception is really important when determining assessing trauma. The next thing is it's highly subjective, kind of like I said, and individualized. So one child removed from an abusive home may experience this as traumatic, whereas another may not. Okay, I just said that. Yeah. And then how the individual labels, assigns meaning to, and is disrupted physically and psychologically determines whether it is traumatic. So that's something to, not to gloss over. And then note, many people deny and or minimize both their traumatic experiences and its impact on current functioning. And many people do. In fact, trauma and PTSD, which we'll touch on here in a second, is one of the most underreported diagnoses. Yep, for a lot of different reasons. Um, like one reason sometimes that I'll kind of talk through is sometimes it could be ego. To say that a person has experienced trauma, for some people, they kind of see that as, okay, I'm less than, or something's wrong with me. I don't want to be labeled like that. Sometimes it's that. Um, Sometimes a patient may, or a student, or a client, patient, they sometimes may need to receive some awareness or some understanding or of what trauma is. Sometimes it's very confusing on what it is. I know the definition that I kind of talked through was a clinical definition, but lay people typically think of trauma as this really big event that has needed to occur, and sometimes it may not be this really big event. Sometimes events that maybe are on a smaller scale, that may still be causing some distress, can still produce trauma symptoms as well too. And that's again why I really like that definition that trauma is an emotional and physical response that overwhelms one's ability to cope. And then this last part here, often clinicians collude with denial. So over-reliance on self-report, lack of follow-up with third parties, not exploring beliefs or ego with trauma. And when we are assessing for trauma, a lot of times we are doing self-report. And other reasons on why that information might not come out is maybe a person doesn't feel comfortable sharing that too. Maybe there's a need for trust that's built before they can acknowledge or report that there is trauma or that there has been something traumatic too. So what we do have is we have self-report, but we know that trauma, PTSD, it's highly underreported. So here's PTSD criteria that I want to touch on briefly. So DSM-5 criteria: traumatic experience, person directly or indirectly exposed to actual or threatened death, serious injury, or sexual violence. So these are basically criterion that are used to determine if PTSD is diagnosed. So with each of these, these need to be considered when assessing if this diagnosis is valid. The first one with the intrusion symptoms, and then the next one, avoidance of trauma. So typically, like, one of these would need to be indicated. And then with the next two, the change in cognitions and mood, and then the hyperarousal, usually two of these would need to be indicated in order for this to be PTSD. And then, of course, these symptoms would need to occur for at least 1 month. And then also, it's important that you are ruling out other things. Of course, there might be medical issues, there may be substance use, and the reason all that's important is because medical issues, substance use can mask, or not mask, but there can be an overlap of symptoms. And so it's important that those are ruled out, and we get that accurate PTSD diagnosis. Okay, so I want to touch on statistics from CDC. Among U.S. high school students in 2023, 40% reported persistent feelings or hopelessness in the past year. 20% reported seriously considering attempting suicide in the past year. 16% reported making a suicide plan in the past year. 9% reported attempting suicide in the past year. 22% report drinking alcohol in the past 30 days. So I think these are important to check out. But the thing when I first look at this, I think of the self-report aspect to it, and um, we know that there's a need, to explore this type of data, as much as we can and even more, just because we can't always just rely on, self-report, as we may not get those folks who would be, willing to acknowledge or, yeah, speak to it. And so, we know that there are people, who are suffering in silence. And so, it's important that we do, kind of look at the relationship with trauma, and suicide, because by addressing trauma, you are decreasing, likelihood of a person, attempting suicide. So, one other thing I want to touch on is historical trauma. And historical trauma, it is the cumulative trauma that affects an individual and continues to affect subsequent generations. That's the kind of working definition for that. And then intergenerational trauma occurs when trauma is not resolved, is internalized and passed on to the next generation. There's a very famous cherry blossom study with mice. I think the study came out around 2013, and they basically found that the mice that were used in this study, they were conditioned to the scent of cherry blossom, and then they were conditioned to an electric shock at the same time. And then over time, the mice would smell the cherry blossom, and then they would then act as if they were being shocked. They would have a physical response, just because of the way that they were conditioned. And the reason why this study is really important, is because as the mice had offspring, the offspring, the mice would smell the scent of blossom, cherry blossom, and then they would have similar kind of reactions, even though they had never been shocked electrically. And then from there, the mice's offspring, so the grand mice, then being exposed to the cherry blossom, they were having the same symptoms as well too. So even that being passed down from generation to generation, just the scent of cherry blossom, and then this physical response, that they were having, even all the way down to the grand mice, was pretty clear that intergenerational trauma is definitely a thing. Lots of studies on this with Holocaust survivors as well too. That there's some predisposition, biologically, and then of course there's storytelling, as well too. And but we do see that, trauma can be passed down intergenerationally. And then the definition that kind of brings those two together, historical intergenerational trauma, is a series of events perpetrated against a group of people and their environment with genocidal intent to systematically eradicate them as a people. Dr. Karina Walters. And so even looking at, slavery, as well too, on how that's impacted, African Americans to this day. There's a great book on this, actually, by Dr. DeGraw, I believe. And it's called Post-Traumatic Slavery Syndrome. Excellent read if you haven't read it. This next point, do not assume that everyone within a group or community or family has been or perceives that they've been impacted by historical trauma or has had the same experiences as others. So that's really important because not everybody identifies with uh, cultural experiences. Not everyone identifies with past historical events, that may have inflicted trauma onto, others who may look like them. And so that's the thing too. We can't assume that people identify, with cultures. That has to be understood as well. And then what we want to do with intergenerational trauma, historical trauma, is we want to affirm resilience. This is just an effective approach, generally speaking, affirm resilience, strength, and persistence of culture. Some other things about culture and trauma. Some populations and cultures are more likely than others to experience a traumatic event or a specific type of trauma. Rates of traumatic stress are high across all diverse populations and cultures that face military action and political violence. So sometimes it's important to know that people are struggling, today with, what's going on in the political arena, what's going on with some of the current wars that we are having. People who have some relations to the political ideology or a people who are impacted. Um, Over in different countries could be experiencing some very could be experiencing some trauma symptoms, actually. I think that's the best way to put it. Culture influences not only whether certain events are perceived as traumatic, but also how an individual interprets and assigns meaning to the trauma. Culture determines acceptable responses to trauma and shapes the expression of distress. Culture affects what qualifies as a legitimate health concern and which symptoms warrant help. Culture shapes beliefs about acceptable forms of help seeking behavior and healing practices. So, with the responses, I already touched on that, but here are some cognitions. Here are some thoughts. Here are some beliefs that people will actually experience in response to trauma. Um, So number one, it's not my fault, or I'm sorry, it's my fault. I'm not a good person. I don't belong. I am unlovable. I'll never be good enough. I can't trust anyone. People are out to get me. Nobody can help me. No one can understand or relate to my story. I am broken. I don't need care. I'm a burden on everyone. The world is unsafe. I need to protect myself at all times. Nothing will ever change. I want to die. So the one other thing, when people experience trauma, people will tend to change their beliefs about people, about themselves, about the world. And then a lot of times people will engage in behaviors that maybe for some time serve to protect them. So like not trusting others, for example. Um, that typically is a response where a person may not trust, and uh, that is their way of adapting. That is their way of surviving. That is their way of protecting themselves. And then over time, we typically see, though, as that may have served some of that purpose, over time, we do see that that then starts to work against people. That no longer serves people in the way that, they may have thought, or in a beneficial way. People are actually start to see where they're not trusting anyone, that problems are now coming their way. And so what did serve as something they adapted to, something that helped them survive, we see typically later on that it actually stops serving in that way and starts to bring on consequences. Here's how trauma can play out in a classroom. And this is really important. And with some of my personal experience, I think this kind of touches on a little bit of it. So tardiness, attendance issues, non-compliance or not listening to instructions, distractibility, sleeping in class, acting out, dishonesty, manipulation, and attention-seeking behaviors, need for control, lack of trust, impaired ability to attach, disassociation, hypervigilance, and then somatic preoccupation. Hypervigilance, it really can just be, a person kind of darting around, always looking behind their back. And then the somatic preoccupation could be someone really excessively fixating on physical sensations or areas of their body. There just may be some fixation there. And so some of these can be looked at as behavioral problems. Some of these can be looked at as, someone not following the rules, or sometimes I think that, staff or even a school official sometimes can see some of these as, well, you're not listening, or you're doing this intentionally, or you're doing this to get a rise out of, or, all those kind of things. But a lot of these really can stem from trauma. uh, these can be behaviors that are played out that may come off as non-compliance, but it really could be trauma, when we look underneath the surface. Okay. And so my hope as we continue kind of talking through the rest of this, my hope is that, when we talk about behaviors that students may be engaging in, my hope is that there's some increased awareness here, and my hope also is that when there are behaviors that are played out in the classroom, that we do start to kind of ask more questions about like what these behaviors, what do these behaviors really represent, which a lot of times can be trauma. So now moving on to trauma-informed care. Um, where are we at with time? Sorry. Okay. Um, So, with universal trauma precautions, it's important that we assume that all people and connected persons with whom you are working are coping with the effects of trauma and modify your practice accordingly. And that's the thing about trauma-informed care within the system, is you want to assume that all people could be impacted by trauma in some way, not just for students, but also teachers as well too, as you are creating, a trauma-informed environment. So just assuming that off the bat, it really helps widen the lens on what changes can be implemented with trauma-informed care. Recognize how your organization, your program, your environment, and your practice could potentially act as a trauma trigger. Um, and so we know within systems, within organizations, like even just sometimes the idea of authority could represent so much to a student. And so, yes, of course, if a person has had traumas specific to authority, parental figures, and then being in a school setting, it really could be triggering in so many different ways. And then recognize that you may also have experienced trauma yourself, and you may be triggered by student responses and behavior. You know, so yeah, so we do talk about in the mental health field, we do talk a lot about transference, and counter transference. Transference being that, yes, students can see you as a parental figure, who might be, abusive to them. We know that with counter transference, there are things that may happen in the classroom, or behaviors you might see that might bring up some of your past as well too, which then influences how you react and how you respond. So it's important that there's constant reflection on what's coming up for you as well too as a professional teacher. Here's a comparison of two systems. A trauma-informed system is one that seeks collaboration and partnership with those seeking services. It is relational. You'll see some examples here of you'll see kind of like basically progress in how we now are looking at making things more trauma informed. Previously, these are kind of older ways of kind of how we went about addressing behavior. So the traditional older way would be, when something's going on with the student, what's wrong with you? Now we're asking what happened to you. Um, We're now, instead of looking at, this being like a deficit focused approach, where we're focusing on, what a student maybe lacks, we're now putting a lot more emphasis in order to be trauma informed on strengths. And so it's important that, you're finding out, what are the strengths of the students. Sometimes I think school officials can make that observation and come up with it on their own, but sometimes it may take even asking students, what are some strengths of yours? And then keeping that kind of at the forefront of the rest of their year school time would be, I think, really beneficial and effective. And then professionally driven process, where there's that dynamic of professional and student, or professional client, student, teacher, I'm sorry, teacher, student. Now we're trying to make that a lot more of a shared experience, where now, in order for this to be trauma informed, we're now taking the approach of seeing students actually as an expert here, an expert in knowing who they are, knowing what they want, and we're treating them as such. Um, and then focus on symptom reduction. Now there's emphasis on understanding symptoms and behavior. And so with more of a trauma-informed approach, instead of that being the sole focus, symptom reduction, now there's a need to build the relationship, sometimes with the mental health diagnosis. As that can be a crucial part of it, or building a healthier relationship with symptoms even. And then therapy seen as primary healing approach, but now with a healing happens within healthy relationships. But now with trauma informed, now kind of looking at, healthy relationships, looking at the community, just broadening how healing can play out is really key and really crucial to the development of patients healing, students healing. Sorry, you all, I keep switching patient and student. Bear with me on that. Um,
That's okay. They understand.
Here's four C's. Donna, where am I with timing? Um,
You probably got like um, maybe 7 minutes, 8 minutes, and then we'll do
okay.
quick questions.
Okay, thank you. Okay,
Okay.
so four C's of trauma-informed care. So four C's right here, and these are concepts to keep in mind, that need to play out in the environment in order for this to be trauma-informed care. So, a sense of calm, being self-aware, reducing any chaos, creating a safe space, even engaging in deep breaths. And sometimes modeling that for students can be really, really powerful. Sometimes doing shared deep breathing, as well, can be, really powerful. And it doesn't have to be at a moment of crisis or high stress. Sometimes it could just be kind of a routine, that helps students kind of engage and see that and engage in that in a healthy way. And then contain, help people feel held, predictable routines, being on time, clear communication. Predictable routines is key, as we all know. That's really powerful at establishing and maintaining some safety in the classroom. When a student can know what's going to happen for the most part, a student knows, your demeanor, how you present, and that being consistent, really does allow for that safety there. Um, Showing compassion, listening without judgment, build resilience, by teaching and practicing skills like stress management, problem solving, and healthy self-talk. Trauma-informed settings really need to have these features involved as well too. The first one, safety, physically, emotionally, and psychologically. This needs to be kind of a staple in the environment. A high level of transparency of what's going on in the school. What are the plans? How are issues being addressed? Teachers being transparent with students is all key there. And then the collaboration, recognition that healing happens in relationships and in the meaningful sharing of power. And then, of course, like building empowerment, in the classroom is really helpful, is really key. And there's lots of creative ways, that can be done. Even when, students have dilemmas on how to handle situations, or sometimes when there's conflict, or even if there's maybe some rule that wasn't, followed, or but one of the things that we typically do is, in a healthcare setting, we typically provide options to clients and patients. And so providing options, even when there's conflict, even when maybe some rule wasn't followed, letting a student choose kind of like what's going to happen is just very, very helpful and very growing. And then the voice and choice, making sure that, yes, that a student has a voice and kind of like what's going on with them is also really effective. And then here's just a little model here. I'm gonna move past this, but let you all kind of see this. Um, so this is something that is definitely carried out in lots of different healthcare settings, making sure to have these key principles to then maintain a trauma-informed atmosphere, and then also to really, help alleviate, trauma. And then this next part, here's some approaches that I'll just touch on just very quick. So with trauma-informed care, with students, if there is a need to really address and explore working on mental health, working on trauma, one of the things that's really key is them working with a trauma-informed therapist. At the same time, also exploring working with a child or adolescent psychiatrist. With the therapist, making sure that, yeah, there's some trauma specialty there is really helpful. With the child adolescent psychiatrist, if there's like addiction, for example, making sure there's some addiction expertise there. Sometimes with psychiatrists there may not be. And then at SunCloud, some approaches that we are taking that are very helpful for our adults are cognitive processing therapy, our CPT. And then for our youth, we are utilizing trauma-focused CBT, cognitive behavioral therapy. These are treatment modalities to really help with the cognitions, really challenge the beliefs that all have stemmed from a lot of trauma that our patients have experienced. And so those are just a couple of options among many. And then for the school officials, for teachers, make sure you all are taking care of yourself too. Establish some coming home rituals. Create clear boundaries with work and home life. Develop routine. Believe before you leave. Talk with a colleague. Journal, to-do lists, organize desk. During your ride home, take care of yourself as well too. When home, take a shower, take a hot bath, all that. Just make sure that you are taking care of yourself. The more you're engaging in self-care, the more you are reducing burnout, the more you're reducing stress, the more you're reducing the likelihood of, not being able to, the more you're reducing the likelihood of re-traumatizing students actually by simply taking care of yourself. Um, so in summary, trauma is defined by events, experiences, and their effects on an individual. Mental health, physical health, and PTSD are intertwined. Trauma-informed treatment is based on principles to identify trauma and facilitate recovery. A trauma-informed system is one that seeks collaboration and partnership with those seeking services. Current evidence-based therapy supports integrated care to yield best long-term outcomes. Okay, that's all I got. It's just a little YouTube thing, but I think we are, yeah, out of time. So yeah, any questions, I guess?
I don't think, Chantrell. There's nothing in the chat right now. Anyone? I mean, we have a lot of school people I know. Oh, they want you to share the YouTube link.
Oh, okay.
Hmm.
Um, wait, I might have to.
Um,
Oh, okay. Let me share this real quick. Okay, the only thing with this video is the use of a kid. I understand that where this is high school, so try to disregard the kid and replace that for student. You know. but it's very valuable, helpful. This is by Dr. Ross, one of the quotes that I mentioned earlier about, the need to get rid of punishment and stickers in the school setting. Instead of looking at behaviors as punishment, or I'm sorry, behaviors and then trying to modify that behavior, taking a more collaborative, compassionate approach is actually a lot, and partnership is actually more key. He's going to touch on that. It's just 2 minutes. I'll play.
Thanks. I don't hear any sound.
Oh, can you hear it, Donna?
No.
No.
Mm-mm. No
No? Oh,
sound.
oh, okay. Huh. Okay. Well, so I
I
do
can
have.
share it actually, like if you want to send me the link, I can share it with some people. Oh, you might just, yeah, we can share, maybe share that link in the chat, or I can share it later, Chantrell, too. Uh,
Okay.
One of the questions was, though, that we did see, just to go back to it, thank you, um, was how to help train like teachers, kind of,
Say it again.
let's see. Um, how can we best train our teachers in this work with trauma?
Who are the best teachers?
How do you best train them? Like
Oh,
there's
best
school people
trainer.
asking, how do we best train our teachers?
Um, I think, my opinion, I think working with a consultant who can come in and do like a training with the teachers will be really, really important. With trauma-informed care, I think this is good information, but I think when we go like down like a whole nother level, there are practical things that we actually can do when engaging with students. Um, in many different areas. And so I think, yeah, to increase the practicality of some of this, working directly with a consultant who can maybe come in for an hour at least, at the very least, once a month or something, I would really encourage that. I do know some mental health care professionals do come into schools, for that reason. So yeah.
I always
Um,
think like one of the best things, like you said, is sometimes just trying to figure out like there might be stuff going on at home, or there might be stuff. So like having teachers just
mhm.
be a little bit more mindful that just because that behavior presents in the classroom doesn't mean they're
Mhm.
just being like a brat, or they're just being, you know what I mean?
Yes,
There could be
yes,
something else happening. And so maybe just like
yes.
keeping that in the back of your mind and trying to maybe learn
Hmm.
more about your students, I guess, you know?
Hmm.
And yeah, we'll talk about Chantal. I don't know if you want to share some of your presentation afterwards.
Yeah, I can share it.
You can
Yeah,
send it out.
I'll
And
send it.
then,
Uh-huh.
okay. And then I don't know if there's no other questions. I'm not seeing anything else in the chat.
Okay.
Yeah, someone said
I
lead
will.
with curiosity, give time for regulation are the big ones that we use. Right. Right.
Mhm.
Like that's a good suggestion.
Yes, it is.
And I think just obviously, if you ever need anything, we're here. Obviously, like the last slide has my name and information, and also Lori Kehoe, my counterpart, who does a lot of adolescent stuff too. But yeah, we're here to help. And Chantrell, thank you so much for sharing your wisdom and your
Mhm.
experience, because it's been invaluable since you've been here. So we're so
Mhm.
appreciative that you're here with us at SunCloud. And thanks everyone for taking a Friday to kind of be out here with us. And then we'll send out like our new series. We'll be starting for the spring, starting in January. So you'll start getting, if you haven't already received that, you will get our 4 kind of new CE events that are happening starting in January. Thanks everyone so much.
Thank you. See you all.